Good morning, colleagues. We have a quorum. It's the appointed time. Because there are no nominations, I will be the chairman. I'm more than willing to serve you all. On 8th of December, during the House Committee meeting, the members agreed that a subcommittee should be set up to study the two pieces of subsidiary legislation. We'll first discuss the policy matters. As we do not have a lot of members, we'll be more flexible with the time limit. We'll first invite the representatives from the administration to come inside the conference room. I'll take this time to ask members something. As we have conducted public consultation before regarding the two pieces of subsidiary legislation, and as we do not have much time at hand, if members have no objections, we can just invite public submissions and there's no need for a public hearing to be held. I do not see any members who wish to make comments, so that will be that. Welcome, representatives from the administration. Mr. Lee, that would be the Deputy Secretary. When you're ready, you may start. Please brief members on the two pieces of subsidiary legislation. Sorry, my voice is not as good as I hope it would be. We want to provide best end-of-life care for terminal illness patients. We are amending the two notices to respect the choices of patients and provide more options for end-of-life care to patients. I will now talk about the background and the details of the amendments. Can you speak closer to the microphone, please? Thank you. In 2019, public consultation was conducted in relation to end-of-life care, and in 2020, the consultancy report was released. It is believed that there is general support for the legislative work on advanced medical directives and dying in place. In May 2023, the Health Bureau briefed the Electrical Panel on Health Services on the legislative framework. The panel was generally supportive of the proposals. The notices will amend Chapter 1504, the Coroners Ordinance, and Chapter 174, Births and Deaths Registration Ordinance, to facilitate dying in place. And in relation to advanced medical directives, AMDs, there will be another bills committee to scrutinize the bill, so I believe we can focus on the two notices in particular. In Coroners Ordinance Chapter 504, there are existing provisions that set out that when certain conditions are met, when patients die at home, there is no need for such deaths to be reported. However, for those that happened in, for the deaths that happened in elderly homes and that are not nursing homes, then these deaths will be reportable. So even when RCHs with good of life programs and hardware and trained personnel, residents are usually sent to hospitals in their final days, resulting in unnecessary hardship and treatment. That's why we are amending Schedule 1 of the Coroner's Ordinance to allow terminally ill patients more options for their own treatment and care arrangements, so that when they are diagnosed with a terminal illness, or attended to by a registered medical practitioner, RMP, during his or her last illness within 14 days prior to his or her death, as well as the cause of death being a natural cause. With all these three conditions being met, the deaths will no longer be made reportable. So we are amending the Chapter 504 Coroners Ordinance as such. In view of the amendments, we are amending Chapter 174 Second Schedule as well, because these provisions are quoted in Chapter 174 as well. That's why we are consequentially amending Form 18 in the Second Schedule to Chapter 174. And the amendments, specific amendments, are set out in the notice to amend Chapter 174 Second Schedule. We will gazette the changes as soon as possible so that we can implement the changes. These amendments will remove the barriers so as to provide better end-of-life care to patients. In view of an aging population, we'll have greater demand for end-of-life care. We will work with the relevant departments to review how to better enhance end-of-life care. I so submit. Thank you, Chairman. It is now time for members to speak. If you wish to speak, please press the request to speak button. I guess we can set 5 minutes for each member to speak for now. Mr. Ring Kong, please. Thank you, Chair. I want to ask about the definition of end-of-life or terminal illness. I do understand there is a medical definition, but I don't think there is a legal definition. To avoid any misunderstanding, would you consider defining the term for terminal illness in the legislation? In terms of operation, for example, if there is a patient who dies in a home, is it the case that the attendance of a medical practitioner is required? If the judgment of the medical practitioner is that the cause is not natural, would there be such instances? My concern is that while it is ideal to provide more options to patients, if we do not provide for the relevant arrangements, for example, the attendance of doctors or nurses, because some cases or in some cases the cause of death may not be natural, I think it may be the case that when they are diagnosed as terminal illness, if we assume the cause of death to be natural, it may be worrying. There may be instances of negligence, or there may be malicious intent. So I hope that this is accounted for in the legislation. All right, thank you. Deputy Secretary, please. This is a good question. In relation to the definition of terminal illness, this term is not new. In fact, in Part 1 of the Coroners Ordinance, it did appear, and in the second part, it refers to those who have died at home. The conditions are that one has to be diagnosed with a terminal illness, as well as attended to by a registered medical practitioner, RMP, during his or her last illness within 14 days prior to his or her death. So the term terminal illness is not new to the legislation, and it would have to be the medical practitioner's professional judgment to diagnose an illness to be a terminal illness. I'll perhaps let Dr. Look talk about the definition of terminal illness in due course. In relation to what Ms. Doreen Kong said about who could determine the cause of death to be natural, I believe there are several safeguards in place. One, the doctor would have to diagnose one to have a terminal illness. This is a medical judgment, and as I said, the patient has to be attended by a medical practitioner during his or her last illness during the 14 days prior to his or her death. And regarding the cause of death to be natural, with one having a terminal illness, it does not necessarily mean that one's cause of death would be natural. The doctor would look at the circumstances, and then they would sign the Form 18, a specified form in the Coroners Ordinance, where the medical practitioner would have to say what the specific cause of death is. I believe with such in place, there are multiple safeguards so that it wouldn't necessarily mean that when one has a terminal illness, one's cause of death would necessarily be natural. I'll now have Dr. Look answer the rest of the Ms. Doreen Kong's questions. Thank you, Chair. Well, with terminal illnesses, it does not necessarily mean one has cancer or otherwise. There are a variety of terminal illnesses. There is, for example, cardiac arrest, lung diseases, or kidney diseases, or dementia. We will have our professional judgment to say that, for example, how many months they would still have before their death. Well, I guess because it is now past the time limit, should you have follow-up, you can speak on the second round. I'll now read out the order of members who are going to speak. Professor Chen Wing-Kwong, Dr. Teck Chi-Yun, Dr. David Lam, Reverend Peter Kun, Lam So-Wai, Ms. Doreen Kong. For the second round, Ms. Lillian Kwok, Mr. Edmund Wong. Professor Chen Wing-Kwong, please. Thank you, Chair. I support the two notices to amend the two relevant ordinances to provide more options to patients to spend their final days in a familiar environment. As for the specific details, I have some questions. In relation to the amendments, as long as the conditions are met, those who have died in homes will no longer, their deaths will no longer be reportable. But I think it is important that the patients would receive appropriate care. So I want to ask if the administration has any measures in place to ensure the patients would receive the appropriate medical care in their homes or in the residential care homes. For terminal illness patients who choose to spend their final days in homes, the homes may think it is not good omen, and they would ask them to leave the homes. How can patients and their family members deal with this? And how will the administration do their dues in terms of education and promotion to provide more options to patients? And for patients who need medical care, for example, breathing apparatus or those that can facilitate their defecation, or urination, would you consider improving the hardware of homes before you implement such arrangements? I also want to ask if all residential care homes have end-of-life care rooms. If not, will these homes be able to receive patients who want to have end-of-life care in the homes? How will you supervise homes to ensure patients would receive appropriate care before their deaths? Thank you.
Deputy Secretary, I thank Professor Chen for the questions. I'll first talk about the principles, and I'll ask representatives from the SWD to walk us through the practical procedures. Well, on this amendment, I'd say we are making the first step. We are removing the legal impediments by putting forward the legal amendment exercise. Well, we are seeing residential care homes of different scales and sizes. Some of them are better prepared for these legislative amendments. Well, at least I'd say we are making the first step to remove the relevant barriers so that residential care homes that have the capacity will be able to adapt to the changes. However, we currently do not have any regulations on the residential care homes. Second point about disputes between care homes and family members. Well, be it the two pieces of subsidiary legislations and the bill on advanced medical directives, well, these are not just pieces of documents. We are trying to implement an advanced medical care plan. We want to have the family members of the patients and residential care homes to be able to reach a consensus. We want to make sure that patients will be able to die in peace. In terms of the practical procedures that will be taken by residential care homes, I'll ask the SWD to elaborate. Ms. Kwan, please. Thank you, Chairman. I thank member for the questions. For this particular legislative amendment exercise, we will talk to the trade and relevant sectors. We will hold briefing sessions so that the entire sector understand the legislative intent as well as the roles of residential care homes and how they can implement relevant measures. On end-of-life care for contract residential care homes, we are allocating additional resources to them so that they can recruit relevant personnel to provide care for their residents. And there will be a set of guidelines that residential care homes will have to follow. They will have to learn how to communicate with family members of residents. We want residential care homes to be able to flexibly deploy resources to set up hospice care rooms for residents suffering from terminal illnesses so that patients can spend their last days of their life in peace with their family. We will provide guidelines to residential care homes, be it RCHEs or RCHDs. We provide training for their staff so that we can enhance the knowledge of these staff in this regard in terms of how to care for terminal patients. Thank you. Dr. Teck Shi-Yun. We welcome improvement in end-of-life care. If we look at countries like Singapore and Taiwan, well, they've been doing quite well in this regard. Well, Hong Kong is falling behind in this regard, but it's better that we're doing something than nothing. However, I'm quite worried. It looks like terminal patients have a choice, but do they actually have an option? Under the current law, there is a trust, and it allows family members of patients to have a trust. And there are very few participants in these trusts. I wonder if there are enough support facilities for terminal patients. As far as I understand, a residential care home will have to have the relevant support facilities in order to provide end-of-life care. Do we have enough medical-social collaboration? For instance, is there palliative care? And also, would medication be provided by care homes to terminal patients? These are all crucial. Also, in terms of the environment provided by residential care homes, do all these homes have hospice care rooms? You cannot just put a terminal ill patient on a hospital bed or on a deathbed. For a middle-sized residential care home, does it have the facility it needs to provide the relevant care for terminal patients? Well, if we don't have these support facilities, even with the law, we won't be able to allow terminal patients to actually have a choice. Well, the administration mentioned that it has to make a first step first, but if we lack the support measures and facilities, the law is not going to serve its purpose. As mentioned, in terms of hardware, facilities, and public education, does the administration have any actual plans? Will there be resources given to the trade? Will there be guidelines provided to the industry so that they know what to do? Thank you. Deputy Secretary, I thank Dr. Tick for the great questions asked. As mentioned, enacting the legislation is just the first step. We have to think about how to roll out support measures. In terms of manpower, we are currently reviewing the services provided. We are looking at how to enhance medical-social collaboration. We are thinking about how to boost manpower. We are thinking about how to improve hardware facilities so that residential care homes can use their beds flexibly. Within hospitals under the management of Hospital Authority, well, some of them are able to provide end-of-life care. While I understand that we need good supporting facilities, as mentioned, we are only making a first step. Apart from enacting the legislation, we are going to improve the hardware facilities. Well, in terms of life and death education, different units are currently implementing that. If I may say a few words about what we've been doing for health department. In the elderly centers and neighborhood elderly centers, there is life and death education. We talk about management of sadness, and we talk about post-death arrangement. And also, we have education provided in primary and secondary schools. The Hospital Authority also gives education on advanced medical care plan. But I agree with Dr. Tech that we need to have more supporting measures and facilities. I agree with what the administration said. Apart from enacting the law, we also need supporting facilities and measures. Can the administration let us know whether it has a timetable to implement all these measures so that when we have the bill passed, then patients and family members can actually be given a choice? We will have the documents ready later. Next, Dr. David Lam. Thank you, Chair. Some colleagues asked some very pragmatic questions. I remember when I was a intern, I remember the nurses would tell an elderly patient to just sit in the hospital to wait. If there's a lack of room in residential care homes, we may have the staff removing a dead body and have another resident lying on the same bed. So what I'm saying is I wonder how much space there is in a residential care home. Are there any hospice care rooms in residential care homes? This is not a rare occasion that I'm referring to. For most of the elderly people who are admitted to residential care homes, they normally spend their last days in the care homes. They do not return to their home, so we need to ensure that there are enough facilities in residential care homes. Another question is about the 14-day requirement. Well, 14 days is not a very long period of time. For someone with cardiac arrest, we may not be able to see the patient within 14 days before the patient's death. Also, it's hard to transport a resident with illness. So 14 days may be a very short window. Would you revise it to a month in your subsidiary legislation? Also, in terms of the actual practice, after a person died, well, the relevant doctor will have to fill out the Form 18. Currently, doctors are unable to fill out the form online. Will have to complete the paper form. So I wonder if relevant barriers can be removed to make the procedure easier for doctors. Also, not a lot of residential care homes have spaces to store dead bodies. They do not have a mortuary. On the 14-day requirement, well, in terms of the duration, under the current Coroners Ordinance, we're sticking to the 14-day window. Well, doctors and different members of the public have divergent views on this. A doctor will have to fill out the Form 18 to certify a patient dead. Some doctors may be of the view that if he is only attending the patient 14 days before the death of the patient, he may not feel comfortable with filling out the form. So should we allow the window to be 14 days or a month? Well, if we look at the current ordinance for patients dying at home, we are making it 14 days, or we are sticking to the 14-day window. So for those who are going to die at residential care homes, I think we should stick to the same time frame. It is not very scientific as we decide whether we should go for the 14-day window or a month window. In terms of Form 18, we will review the relevant forms. There are various forms that we have to fill out after a person died. So we will review all these forms and procedures. In terms of the point about residential care homes and regulation on care homes, whether we impose any requirement on care homes to ensure that they can provide end-of-life care, I'll defer this to my colleague. I thank Dr. Lam for the questions. On the hardware facilities of residential care homes for new contract care homes in the new specified list that we impose on residential care homes, hospice care rooms are included. We ask these hospice care rooms to be designed like homes so that residents can die in a familiar environment. So we do impose certain requirements on residential care homes. We understand that some care homes may not be able to meet the requirements right away. Well, we have amended the Residential Care Homes Ordinance, and we ask residential care homes to provide enough space for their residents. We want to make sure that care homes have hospice care rooms to provide a familiar environment for their residents. Well, will you come up with a timeline to follow up on residential care homes that saw poor facilities? Well, I was referring to new contract care homes. For care homes under current contract or for subvented care homes, we encourage them to flexibly make use of the existing space of their homes to set up hospice care rooms for their residents. If they need additional resources to do that, we will help them apply for resources. I think the point made by members is that you have to add certain clauses or provisions in your contracts with the care homes so that you can make sure that care homes can comply with the relevant requirements. Do you have plans to do so? We will review the situation and will decide what to do. Perhaps in the next meeting, in the administration's written response, you can include this point. Also, Dr. Lam mentioned about whether Form 18 can be made electronic and whether doctors can fill out the form remotely through electronic means. You can think about this. Well, it's not quite acceptable that we simply do not roll out electronic forms just because we want to stick to the usual practice. I think you can think about whether you can allow doctors to remotely fill out the forms. Well, Dr. Tick asked for some responses from the administration. Perhaps you can respond to Dr. Lam's question in the same response.
Sorry, I have a follow-up, Chair. I think it is also important to make sure that there is cold storage facilities. Thank you. Next, Reverend Peter Kuhn, please. Thank you, Chair. I think the legislative amendments are definitely good, that they provide more options for terminally ill patients. But the problem that this has is that homes may not be able, or homes may not want to implement such arrangements. When you have 3 conditions to be met, I think these are quite hard to meet. One has to be diagnosed with a terminal illness. 2, one has to be attended to by an RMP during his or her last illness within 14 days prior to his or her death. And these would be used as excuses by the homes so that they can send the patients back to the hospitals. If we make the conditions too strict, homes would just think, oh, since the conditions are so strict, might as well not do it. For independent homes, they may be more than willing to do so, but then it may be hard for them to comply with such conditions. I believe that with the cause of death being natural, that is more than enough. What does the administration think about this? Thank you. Well, thank you, Reverend Kuhn. We did consider different options during the public consultation in 2019. Some have expressed that there was varying quality of homes, which is why it is believed that we should be prudent. And as Dr. Luke said, regarding definition of terminal illness, there aren't specific terminal illnesses. It's just that when one reaches the final stage based on medical judgment, one's illness would be considered a terminal illness. And for whether the cause of death being natural alone would be enough of a condition, I believe there should be more safeguards in place. Because with dying in place, even when one dies at home, there was the 14-day requirement in existing provisions. Of course, we want to facilitate dying in place, but then we also have to ensure that the interests of members of the public are protected. We believe we have struck a balance between respecting the wishes of patients as well as putting in place safeguards. Any follow-up, Reverend Peter Kuhn? Well, in fact, I would like to follow up on Reverend Kuhn's point. As Reverend Kuhn said, some homes may not be willing, or there may not be incentives for them to facilitate such arrangements or to meet such conditions. Even if you removed restrictions with the legislative amendments, there should be facilitation, or even it should be made mandatory in the provisions in the residential care home contracts that they should facilitate end-of-life care arrangements for patients. Well, we'll definitely think about that, but we do not want to impose more conditions for homes. This is supposed to be something that is facilitating instead of causing a burden for homes. I believe that would not be ideal for the work of the Social Welfare Department either, but I believe the Social Welfare Department will consider implementing arrangements that would facilitate the work of homes. We are not trying to force homes to meet certain requirements by a certain date, but we do want homes to facilitate dying in place in terms of hardware and software. I believe once we have implemented appropriate arrangements, more homes will be willing to facilitate the arrangements of dying in place. I'll let Ms. Kwan supplement my answer. Thank you, Chair. I think it depends on how prepared people are physically and mentally. We will definitely liaise with homes before the implementation of the legislative amendments, and we can have some homes that have already implemented end-of-life care arrangements share their experience with other homes. Thank you. Ms. Lam So-Wai, please. Thank you, Chair. I do appreciate the legislative amendments removing restrictions for terminally ill patients to die in place. Whether they plan to pass away in their own homes or residential care homes, it is important to provide options to these patients to spend their final days in peace and in dignity. And in a Chinese society, I believe it's very important that we have to make sure people understand what it means by dying in place, whether it will be unlucky, as people say before. I believe public education would be very important in this regard. I did work in end-of-life care before, and I've worked with relevant departments and NGOs that have provided hospice care or end-of-life care, but one or two department or organization alone won't be enough. We have to enhance people's understanding, especially the family members of terminally ill patients, that they have to be prepared for their family members to die in place. We also need to enhance support for terminally ill patients as well as family members. In certain homes, there are end-of-life care homes or care rooms that would allow for sufficient opportunity for patients to say goodbye to their family members. Would you consider, however, implementing specific facilities for different religions so as to facilitate people's their spending their final days? There may be certain homes that have implemented that, but not in certain contract homes. It is because they do not have adequate resources to support the implementation of such arrangements. Regarding people who choose to die in their own homes, I think there should be a review of legislation in this regard to improve end-of-life care for them as well. For certain patients who have already signed advanced medical directives or their family members who have signed such AMDs, do they really have adequate understanding to prepare them for dying in place or dying in their own homes? Or is it the case that in the end the patients would still be sent to hospitals and then they would have CPR done on them? It is obviously against their wishes. I believe we need to have review legislation to make sure the arrangements are indeed implemented. Life and death education is important and grief management is also important. I hope that the Health Bureau can work with social welfare organizations to help terminally ill patients to be more prepared. Well, most would be opinion. Does the administration have anything to add in relation to what Ms. Lam So-Wai said? Well, thank you, Chair. It is as Ms. Lam So-Wai said, and that is exactly what we have in mind. In relation to cremation, burial, or various burial methods, of course, it is hard for family members with them having to overcome such grief. We will definitely think about how to do better in relation to grief management. This relates to mental well-being, and the Mental Health Committee has focused on grief management, and they have deployed resources to facilitate NGOs to conduct activities in relation to grief management. We'll see what we can do more in terms of provision of life and death education as well as grief management. Social Welfare Department, you have something to add? Yes, thank you, Chair. Well, in fact, we will provide counseling for family members after the passing of terminally ill patients. Chair, I have a follow-up. Well, Assistant Director, I'm sure you know very well the work of homes for small and medium-sized homes. I hope that you can provide the adequate resources to these homes. There are 30% public homes and 70% private homes, and I believe one should make sure there are enough resources to implement such end-of-life care arrangements. Thank you. Next, Ms. Lillian Kwok, please. Thank you, Chair. I think I do support the legislative amendments because the amendments would provide more options for patients and family members. This is a good start for some small and medium-sized homes. They may not have adequate facilities. I want to ask if the administration, as other members asked, that you would provide more support or funding to homes to enhance their facilities to implement better end-of-life care. And as said by the administration, after the residential care homes legislation amendments ordinance, after its passing, there has been improvement, but then will you consider improving even more aspects of homes? In fact, my family member is a nurse. I asked if they saw that they have seen a person dying in front of them, and actually that did not happen because patients are often sent to hospitals. I want to ask specifically regarding the 14-day requirement. When there are outreach doctors who would visit homes, do they visit the homes every month, every 2 weeks, or every week? Can you answer this question first? Thank you.
Dr. Luke can perhaps answer part of the questions first. For outreaching services, well, for the Geriatrics Subcommittee, we have started the services from 1994. We manage end-of-life care services provided. Well, over the past few years, we offer end-of-life care services, but we mainly help patients create advanced medical directives. Well, I mainly want to know how often doctors visit residential care homes. They visit these care homes once a month. This is what I want to know because some of my family members are in the industry. I mentioned this because we've been talking about the 14-day window. If you ask doctors to visit care homes once a month, we can ensure that these doctors can attend to residents in need. So this has to do with our discussion just now with about the 14-day requirement. Well, I understand that there are outreaching services provided, but these services cover lots of residential care homes from different districts. I wonder if more manpower will be given to support palliative care services in hospitals. Well, there are different arrangements in relation to the kind of medication patients need. Some will need morphine, some will need other types of painkillers. So different arrangements will have to be put in place. As a family of a terminal patient, well, we want to make sure that terminal patients can spend their last days of life in peace. So will you review the medication received by terminal patients in residential care homes? Also, I want to talk about mental health. I want to talk about support given to families. Can you review the operation of departments giving palliative care? Will there be nurses that follow up with the situation of family members? Will they offer counseling to family members of patients? I think there has to be medical-social collaboration. There has to be communication between SWD and different parties so that we can come up with some kind of indicators. This will help us offer support to terminal patients and their family members. Thank you. I encourage members to express their views. However, we have to stick to a scope in our discussions. End-of-life care services is not part of the scope of the discussion. I understand that members are concerned about how or what kind of supporting facilities and measures that can be in place to tie in with the subsidiary legislations. In terms of the questions asked by Ms. Lillian Kwok, does the administration have anything to supplement or add? I'll talk about the support given by the hospital authority on CGAG. Well, we do not only visit residential care homes for the elderly or LCHEs. We offer training and support to staff of RCHEs as well. So we're not only sending doctors to attend to residents or patients, we're offering training and we're going to step up this kind of support. Next, Mr. Edmund Wong. Thank you, Chair. I support the 2 pieces of subsidiary legislation. I'd like to see clarifications from the administration, however, on a few points. For residents who are dying, they normally have to be sent to the hospital, and a doctor will sign the certificate of the cause of death after the resident dies. Understand that officers from the Fire Services Department can also help prove that the patient has died and to give directions that the body should be sent to the mortuary. If we find that a terminal patient has died, will there be a registered medical practitioner declaring the patient dead before the body is sent to a mortuary? There may not be a professional paramedic in a residential care home to prove that the patient has died. What if the patient has not died? There may be legal issues arise. So who can prove that the terminal patient at the residential care home has died? That's my first question. Secondly, if a registered medical practitioner is called to the scene to declare the patient dead and a certificate of the cause of death will be signed, well, let's say a patient has lost his vital signs, has lost his breath, for instance, and within how much time will a registered medical practitioner have to be called to the scene? Well, there are problems that we have to deal with. For instance, problems involving the estate or of the deceased patient, how the estate should be distributed, etc. Deputy Secretary, in terms of dying at home or dying at RCHEs, we have to make sure that all the relevant or required arrangements are in place. There are very few cases where we need to find someone to prove a patient is dead. Say all the preparations are ready and the patient knows that he wants to die at the residential care home. Well, nurses at care homes will have received certain training, and the nurses will know that the patient has come to the final stage of his life. After a patient or after the patient has died, doctors will be asked to come to the residential care homes to sign the Form 18. So we will have to make sure that all these arrangements are in place. In other cases where no preparations were made and no arrangements were put in place, we'll have to understand the wishes of the residents first. Normally, there are nurses in residential care homes or staff in residential care homes that have received relevant training. As mentioned, after the subsidiary legislations are passed, we will step up training and publicity among residential care homes. I have a follow-up question, Chair. Just now, the administration mentioned that there are nurses at residential care homes. According to the legislations, there are registered nurses in different residential care homes. What I want to say is that in Hong Kong, we want to prove a person is dead. We need a registered medical practitioner. And this is under Cap 164, or an officer from the Fire Services Department or a paramedic will be able to prove a person dead. Just now I asked about within how long a registered doctor will have to be called to the scene to prove a person is dead. What are the relevant guidelines currently? If there's no law stipulating that a registered doctor has to be called to the scene or sign a Form 18, say you call someone from FEHD to the scene and it is found that a Form 18 has to be signed before the dead body has to be removed or sent to somewhere else. Well, there were cases in the past like these. I have come across cases where a fire service officer got to the scene and found that resuscitation had to be made and the patient had to be sent to the hospital. Well, even with the prevailing legislations, there were cases like these. So I wonder, with the two pieces of subsidiary legislations, how are you going to deal with such situation? Well, Deputy Secretary, under the current law, there isn't a time stipulated when the Form 18 has to be signed. If you have to ask a doctor to sign a Form 18, you shouldn't wait too long. That's the first point. Secondly, you mentioned about the involvement of FEHD. Well, in terms of dying at ICHEs, the normal procedure is that a patient dies at a care home and then we'll have a doctor sign the Form 18. Then the residential care home concerned will make arrangements to remove the dead body. And this does not involve FEHD. If we involve FEHD, then the body will be sent to the public mortuary. However, we're now talking about dying at ICHEs, and we want to exclude FEHD or public mortuary in the procedure. So we are exempting the procedure of having to send the body to a public mortuary. So under the proposed legislation, we'll have the doctor sign the Form 18 and then we will make arrangements to have the body sent to a funeral facility or parlor. Will you clarify this with RCHE so that they know what to do? We will come up with a flow chart or a guideline for RCHEs in the future. I don't want to give too little time to each member, so we have listened to quite a number of members already. I'll give 5 minutes to each member again for the second round. Ms. Doreen Kong, for paragraph 16 under Schedule 1 of Coroners Ordinance. Well, according to paragraph 16, deaths at residential care homes have to be reported under the current ordinance. Paragraph 16 only exists in laws in Hong Kong. In other countries like Singapore, New Zealand, or Australia, similar coroners' ordinances do not have such requirements. So how come in Hong Kong we ask deaths at residential care homes to be reported, and now we're talking about removing the relevant legal impediments? So the administration is now proposing to amend paragraph 16, and this I understand. My worry is that by imposing these additional conditions, does that mean we are removing the legal barriers? In other countries in the world, in similar or comparable coroners' ordinances, especially in countries following common law, they do not have such requirements or conditions. For the 4 points to be included in the revised paragraph 16, are they helping to remove the legal impediments? Should we think about removing paragraph 16 entirely? That's my first point. Secondly, the administration is saying that they would like to provide more options to patients. We have no disputes on this. My question is, for the administration, the law is currently very rigid, and that means we aren't allowing residents at care homes to die at care homes, or is it because residential care homes find it inauspicious to have residents die at care homes? That's why we don't have this in the current law. Have you done survey or consultation with residential care homes? How much is it because residential care homes cannot afford to have the residents die at care homes? That's why we didn't have the relevant requirements in the current law. Finally, about the definition of terminal illness. The administration mentioned just now there isn't legal definition of terminal illness. Perhaps the doctors here can share with us their thoughts. Are there clear guidelines under the law to define who a terminal patient is? In 2022, the 2002, there was a paper that I can share with you all. It was mentioned in the paper that in 2002, there was a paper from the Hospital Authority on how to care for terminal patients, and there was a mentioning of who a terminal patient is. It was mentioned that we had to look at the time for which a patient suffers from terminal illness. If a deceased is diagnosed as having a terminal illness before the death, then it's not a reportable death under the proposed legislations. Well, do we have a standard for this? If not, that would be very problematic. Also, what do you mean by before the death? Are you referring to 14 or 15 days before the death? Also, most of the countries in the world, in relation to the ordinances concerning terminal patients, well, say in Singapore, for Advance Directive Act, in Singapore, there is a very clear definition of terminal illness. In New Zealand, in the UK, and Australia, etc., there are also clear definitions of terminal illness in their laws. Can the administration give us clear guidelines on this, please?
Thank you. The policy intent is that we won't set a legal definition on terminal illness. We have talked to the DOJ, Department of Justice, on this, and it is believed that it should be left to medical judgment. And in fact, the term terminal illness, as I said earlier, is found in the existing provisions. I do not personally see any problem with the term not being defined in legislation, as it is dependent on professional judgment. And in fact, if we set a legal definition, it is hard for medical practitioners to implement, and I don't think we can set a clear legal definition in the first place. As for what Ms. Doreen Kong said about our aim, in fact, as I said earlier, we have conducted public consultation in 2019 in relation to end-of-life care. One part of it was Advanced Medical Directives, AMDs, and the second part was dying in place. And the dying in place would involve dying at their own homes and dying in residential care homes. For the circumstances relating to dying at people's own homes, the arrangements are covered in existing provisions in the Coroners' Ordinance. However, for deaths in residential care homes that are not nursing homes, they are not covered in existing provisions. So essentially, we're trying to plug that loophole. For homes that can implement end-of-life care, we believe with the legislative amendments, they will provide another option for terminally ill patients. I believe what Ms. Doreen Kong was asking was whether you have removed all the restrictions, because as said by Ms. Doreen Kong, in Australia and Singapore, they do not even have such provisions for residential care homes. Have you drawn reference from the laws of other jurisdictions when you draft drafted the legislative amendments. And as we know, Australia is quite progressive in end-of-life care. Is it unique to Australia and Singapore that such arrangements have been implemented, or is it quite common? Well, we did study the laws of other jurisdictions, but I believe we need to draw reference from the local circumstances as well. As said, we have conducted a public consultation in 2019, and we understand that the circumstances in Hong Kong are different from other jurisdictions. We believe the legislative amendments that we have drafted would be more prudent, and it has struck a balance between providing more options to terminally ill patients as well as putting in place safeguards. Ms. Dorian Kong, if you wish to speak again, you can speak for the third round. Next, Dr. Tik Chi-yun, please. Thank you, Chair. As said by other members, I believe we need a host of support measures to facilitate dying in place. In terms of legislation, I believe from what I heard, we all support the amendments, but we are just concerned about whether these can be implemented fully. And as other members said, patients are often sent to hospitals in the end because there are inadequate facilities or support. And it is hard for terminally ill patients to be conveyed to other facilities in the first place. While the legislative amendments would allow for more options to be provided, but are these options actually available? That is the question. Such as the Special Needs Trust, I think it is not doing what it is supposed to do at the moment. We really need to look at this closely to make sure we can indeed provide such options for terminally ill patients. We want to make sure we can implement arrangements to facilitate homes to provide such options. And I think most homes want to implement such arrangements. A lot of social welfare organizations have been providing life and death education to elderly persons. I believe the social welfare sector wants to provide better end-of-life care, and funding has been provided to homes to implement the specific home scheme that can provide better end-of-life care support. So I want to ask if the administration can provide more resources and funding to homes to make sure such end-of-life care can be provided. And Chair, I think we may need to have a public hearing to consult the relevant stakeholders again to make sure homes can actually implement such arrangements. I believe most people want to do more, and that we do in fact want to do more, but the administration has to resolve the problems faced by homes by providing more resources and funds to them to make sure that the other end-of-life care options can indeed be provided to patients. Well, I think we have to be practical. I think most members are concerned about whether the laws have passed and then that would be it. I can assure you, Chair, that this will not be the end with the passing of the law. We will definitely review our arrangements to make sure we can enhance end-of-life care indeed. And in fact, the Jockey Club scheme, the end-of-life care in residential care homes for the elderly scheme, JCECC, is exactly what we have drawn reference from, and we are drawing reference from the project, the Jockey Club End-of-Life Community Care Project, to make sure we can provide the right end-of-life care options for patients. Well, I think we must have another meeting due to the limited time we have available. I believe the administration can provide more information before the next meeting for members' reference. Ms. Lam-Soo-Wai speaking for a second round. Thank you, Chair. I agree with what the chairman and other members said, that we should draw reference from the experience of other places such as the mainland. And I think we can do more in terms of social policy and enhancing public understanding. I have heard what the representative from the Social Welfare Department said about training would be provided to staff members of homes in relation to dying in residential care homes, whether it's the nursing homes, elderly care homes that are not nursing homes, as well as residential care homes for the disabled, RCHDs. They have a great manpower shortage, and right now we already have one staff member handling 4 to 5 chronic patients. With the passing of the laws, they will have to deal with an additional workload. How can they handle that? In relation to dying in their own homes, we need to make sure we can work with the hospital authority to make sure there are nurses in palliative care that can provide the right support to patients as well as their family members. And for family members, they may be able to accept the fact that their family members are going to die at homes, but what about their neighbors and other people? There is still this understanding in Chinese society that with people dying at home, that will bring about bad luck. We really need to do more in terms of public education and social policy so that there is a change in such understanding. We really have to do more. Thank you. Well, thank you. I think we are just repeating what was said in relation to policy matters. I hope that members can give sufficient time for the administration to talk about what is specific to the legislative amendments, because these policy matters can be discussed in the relevant panel. Well, that's it for what I have to say at the moment. Deputy Secretary, anything to add? I do note the comments made by Ms. Lam-Soo-Wai. Thank you. Mr. Edmund Wong, please. Thank you, Chair. In relation to what the administration said about registered medical practitioners, after they have signed the Form 18, the patients won't be sent to public mortuaries. They would just be sent to funeral homes. Right now, the deaths at residential care homes would be sent to public mortuaries, and for those who have died in hospitals, they would be sent to funeral homes. But before that, of course, they would receive appropriate care or handling. But now, with the conveyance from residential care homes to funeral homes, it is now going to be different. Would you set a time limit for homes to make sure the bodies would be conveyed to funeral homes within that period of time? It's not just about superstition. I believe it's about hygiene. If the bodies are stored at homes for a relatively long period of time, it may cause problems with hygiene. So we should implement appropriate arrangements in that regard. Thank you.
Deputy Secretary, I don't have the relevant information in hand now. Well, normally, I guess Mr. Luke, Dr. Luke can also supplement on this. We have requirements on how to handle a dead body. Dr. Luke, if a resident dies in residential care homes in a room with air conditioning, as far as I understand, a body can be kept in that room for 1 to 2 days without any problems. The most ideal situation would be to have a registered medical practitioner within 12 hours to sign the certificate. Clinical judgment would be made by the doctor to decide whether the patient has died. Then the residential care homes concerned will have to apply for Form 12 for the patient's or the deceased family members. Then the body will be sent to a funeral parlor instead of the public mortuary. That's the normal procedure, I understand. It seems like there are no black and white guidelines on this, so Mr. Edmund Wong's question is whether there can be clear provisions in our law, even without legislative enactment, that guidelines should be provided to residential care homes, say, within how long a registered medical practitioner has to come to the scene to declare that the patient is dead. Do you have any thoughts on this? Yes, Chairman, you're right. After the enactment of the legislation, we'll provide guidelines on this to residential care homes. I hope this won't be empty talks by the administration. Yes, Mr. Edmund Wong. Well, according to the administration, normally, if it is not very hot weather, there should not be a lot of hygienic issues in relation to storing a body for 12 hours. Say, if the weather is hot and the body will have to be kept at the residential care home for 24 hours, we'll have to wait for the funeral parlor to transport the body. So there are hygienic issues that we have to consider. Also, in terms of dying at homes or dying at ICHEs, we want to prevent people from breaching the law inadvertently. For Form 12, well, say a patient has died for, say, 30 to 35 months, a burial will have to be carried out. Otherwise, preservatives will have to be injected to the body before a lawful burial is carried out. So this has to do with whether we have to wait for a registered doctor to come to the residential care home to sign the certificate of death, and when people from the funeral parlor will come pick up the body. So I believe the administration will have to look at legislations concerning the burial of a body or the handling of a body under the current legislative framework. Reverend Peter Kun. We are trying to encourage patients to die at residential care homes or at their own homes. Understand that the conditions set out by the administration is to provide safeguards to patients. I think the worry is that whether the patient can meet the relevant conditions. Say a patient may have to go through autopsy if he dies at a residential care home. However, if the patient dies at hospital, we can make sure that there are some people who can attend to the patient. Say a condition cannot be met under the subsidiary legislation, then the patient will have to be sent to the hospital. Well, we want to provide more incentives to facilitate the implementation of dying at residential care homes or dying in place, so that patients can spend their final days in peace without having to be sent to hospitals. Are there any ways to reassure elderly people with illnesses? Understand that you are trying to provide safeguards by setting out all these requirements and conditions. However, what if a patient opts for dying in place and he cannot meet one of the requirements and he will have to be sent to the hospital in the end? So I hope that you can think of more scenarios and then come up with corresponding support to patients in need. We want to incentivize people to opt for dying in place. We don't want to deter family members from not choosing to die at place. Deputy Secretary, there may be such scenarios as mentioned by Reverend Peter Kuhn. In terms of dying at RCHEs, well, we want to make sure that preparations are made by both RCHEs and patient's family. If in the process such arrangements cannot be made or such preparations cannot be made, then we'll have to go for the normal path. That is, the patient will have to be sent to the hospital authority. It's hard for us to prevent all these scenarios or situations by implementing the subsidiary legislations. We want residential care homes to try their best to comply with the law once the subsidiary legislations are passed. We want preparations or good preparations to be made by both RCHEs and patient's family. Whether we should ensure that full preparation can be made or should we make the first step first by passing the law, then I guess we have to think about this. Ms. Doreen Kong for the third round. Well, Chairman, I'd like to thank you for not setting a time limit for members to ask questions. My supplementary question is, will we have to facilitate the implementation of dying in place for patients and their family members? I've read the amended paragraph 16D under Coroners Ordinance proposed by the administration. I think it's a bit redundant. I don't think it's removing any legal impediments per se. Chairman, I think if we do want to remove legal barriers, we want to facilitate terminal patients and their families, we have to think about whether we should remove the entire paragraph 16 entirely. I guess this is not possible. Perhaps we can add Part D to the paragraph 16 and just add nursing home to paragraph 16 apart from residential care homes. I've looked at the schedule to the Coroners Ordinance. For those who are killed, who starve to death, well, these deaths will have to be reported to the coroner. Why do you have to have conditions 2, 3, and 4? I think Part D of paragraph 16 is fine. I think we are imposing unnecessary conditions that deter terminal patients from opting for dying in place. Also, I think these provisions are very half-hearted. The administration doesn't seem like they actually want to help alleviate the concerns of terminal patients and their family members. Also, if we do not have the courage to remove this part and we stick to D1, 2, 3, and 4, say the deceased was before the death diagnosed as having a terminal illness, well, this is a condition to be met. Well, then you have to come up with a clear definition for terminal illness. Well, you're now telling us that you do not have a clear definition. We should not deal with it in such a rough manner. If we set out D1, 2, 3, 4 as the prerequisite conditions, then we have to make these conditions clear instead of making them ambiguous. Lastly, what I want to say is that it's unclear what you mean by before the death. say I'm a family member of a terminal patient, I have to ask the doctor to make a note saying that the patient is diagnosed as having a terminal illness. In 2002, the hospital authority issued a guideline in terms of how to offer help to terminal patients. This guideline was reviewed in July 2023, and in paragraph 2 of the guideline, that is mentioning about the definition of a terminal patient. A terminal patient is suffering from advanced or irreversible conditions and fail to receive therapy, having a short life expectancy for weeks or a few months. If these are conditions, then perhaps officers from the DOJ can tell us whether this kind of definition is applied to this subsidiary legislation that we are discussing. How do you measure weeks and months as mentioned in the hospital authority paper? It looks like there are more and more problems that we have to solve before we pass the legislation. Deputy Secretary or Mr. Gilbert Moe can supplement or can offer help on how the administration can follow up on this issue. I'll ask the DOJ to talk about the legal definition of terminal illness. Chair? If we do not have a legal definition in this sense, then the court will interpret the term natural death. Well, this is a term that falls under a professional realm. If we need the interpretation of the court, then the court will look at the common interpretation among the medical sector. Our instruction is that there is a consensus in the medical sector and there is no problem to stick to the current wording. We don't think that it is necessary to have a clear legal definition of terminal illness or terminal patient. If we find it necessary to have a definition, we'll try our best to draft up the relevant provisions. If the definition isn't clear, then people may be deterred from opting for dying in place. Then what's the point of having these subsidiary legislations? What's the point of removing the legal impediments? Can we actually facilitate the implementation of dying in place even if the legislations are passed? Also, Ms. Doreen Kong mentioned about whether the administration has the courage to remove the entire paragraph 16. Understand that government officials have reservation on this. You tend to make progressive changes and make steps in incremental approach. I think you are leaning towards not dealing with all the issues in one go, like the bold approach suggested by Ms. Doreen Kong. However, we are under the impression that the administration is not doing enough and you're only proposing the subsidiary legislations for the sake of it. How can we ensure that we can offer enough protection to terminal patients and their family members? How can we encourage them to opt for dying in place? Do we have to end up seeking help from the coroner in this? Will the administration promise to review all these? On the definition of terminal illness, as mentioned by representatives of DOJ, some of the terms and wording, we want to leave it to the professionals to make the judgment legally. For professional terms, especially medical terms, if we are to impose a definition, there may be changes that we have to make in the future. We may have to revise the law in the future if there are changes, and this may not be a very appropriate approach. Our view is that we should leave it to the professionals to make a judgment on what it means by terminal illness. The coroners are currently following a certain interpretation in terms of what it means by terminal illness. So we want to stick to this practice. It's not like we cannot pass the legislation without a clear legal definition of terminal illness. If we impose a definition, then it may cause problems to doctors. Doctors may have to make a judgment both medically and legally. And then we may not be able to achieve the effect we want to achieve by passing the legislations. Also, on the point of whether we are making a bold step or not, we have solicited views during the consultation exercise. We want to take a prudent approach. We have to look at the situations in Hong Kong. We have, or we see differences in terms of the scale of residential care homes and the quality of services they provide and the manpower they have. If deaths in nursing homes are not reported or are not reportable, then there may not be enough safeguards for patients. So we have to strike a balance in this regard. We're looking at subsidiary legislations now. After the subsidiary legislations are passed, we'll have to spend time on educating the public. We'll review the effectiveness of the subsidiary legislations and perhaps make changes accordingly.
In fact, Deputy Secretary, do you have any figures for the deaths, the number of deaths in hospitals and number of deaths at homes? And we can compare the figures after the laws have passed to review the situation to see if people are indeed scared to go for other end-of-life options. I guess you can, with such figures, implement the right arrangements. I understand what you're saying, Chairman. Most of the deaths take place in hospitals at the moment. There aren't that many cases where people have died at homes. With the passing of the legislative amendments, I understand that there may not be a significant increase in the number of cases where people would choose to die in place. And whether there would be significant differences in the figures, I don't think it can be observed at the moment. But would you be able to chart such figures? Yes, we can do that. Thank you. Ms. Lam So Wai, please. Thank you, Chair. Thank you. I'm speaking for the third round. In relation to the legislative amendments, it is said that it would remove certain barriers. But if we take a macro perspective, we really have to think about, with dying in place, whether it is dying in their own homes or in residential care homes. We do have end-of-life care services at the moment, but for those who have died at home, when will their bodies be sent to mortuaries or the funeral homes at the moment? This is echoing what Mr. Edmund Wong said. In the mainland, it's actually very quick. There may not be even time for people to say goodbyes. Right now, is there any plan for the administration to set a time limit for bodies to be conveyed to funeral homes and funerary arrangements. I do understand that you do not want to make too many changes because it may affect other legislation, but I hope the administration can think about these aspects. Alright, let's see if the Deputy Secretary would have clear guidelines to residential care homes in future. As said earlier, we will provide clear guidelines to residential care homes in future. In fact, the Food and Environmental Hygiene Department has published a brochure on funerary arrangements. In simple wording, they have talked about how to make funerary arrangements. And in fact, we have joint offices that consist of staff members from FEHD as well as the Immigration Department to facilitate family members registering their family members' deaths. Thank you. Well, we were supposed to end at 12:30. I'll extend the meeting by 15 minutes. We were supposed to end our meeting at 12:45. Oh, so we do not need an extension at the moment. I think as the wording is quite simple, I have allowed more time for members to speak about policy matters. I believe members should have sufficient time to speak. In fact, I have observed that most members are very efficient in this term, but members are not allowed as much freedom and time to speak. So I have adopted the approach to allow members to speak freely, or as freely as possible. If no members wish to speak for the fourth round, we can perhaps go into clause by clause examination, and who will be the representative from the administration that will be going through the clauses or the sections. We'll use the Chinese version, please. Okay, I'll perhaps make use of the mocked up copy. Let's first talk about the Coroners Ordinance Amendment of Schedule 1 Notice 2023. That is CB brackets 41110/2023 (02). The amendment would start on page 4 of the mocked up copy. We have put the existing provisions, for example, for relating to the deaths in a hospital and a scheduled nursing home, as well as a nursing home within the meaning of residential care homes, elderly persons ordinance, to 16, the new paragraph 16 in ABC. We've only added paragraph 16D, 1, 2, 3, 4, as well as E, 1, 2, 3, 4. Paragraph D relates to residential care home for the elderly that are not nursing homes, and for subparagraph E, it relates to residential care homes for persons with disabilities, RCHDs. In subparagraph D, they have excluded the residential care homes that are nursing homes because nursing homes have already set out in subparagraph C, and some conditions have been imposed in paragraph D. For example, the deceased was before the death diagnosed as having a terminal illness. 2, a registered medical practitioner has attended the deceased during his or her last illness within 14 days before the death. And 3, the cause of death stated in the certificate of the cause of death of the deceased is a natural cause. The same applies to RCHDs. As for the rest, there are no amendments. So as I said, the main amendment is with paragraph 16. That's it for what I have to say in relation to Chapter 504 notice. We have 2 members who indicated their intention to speak. Mr. Kong, please. Thank you, Chair. I can see that in paragraph 16, they say that it is any death of a person that occurred. In the Chinese version, they have used the verb form of dying instead of death. Why don't they use death as a noun instead so as to ensure consistency? My other point is that for point D, that is a paragraph D, I can see that in relation to terminal illness, it is said here the disease was before the death diagnosed as having a terminal illness. In the Chinese version, however, it is different from Part 1, Schedule 1, Point 2. As they refer to the same thing, why is it that in the Chinese version it is different? And again, I understand that the administration has their stance on the definition of terminal illness, but again, I think there should be better definition of terminal illness in the amendments. Well, regarding Mr. Kong's first question in relation to whether the word death should be used across the board, in fact, I think in the English version there's also the verb form of die. We think when we drafted the amendments, we think that it would be more grammatically correct, or it would be less redundant if we use the verb form of die in Chinese. We believe what we have right now is appropriate. In paragraph 2, it says that a person who before his death was diagnosed as having a terminal illness, as said by Mr. Kong, the English version is the same in both paragraph 2 and paragraph 16. With paragraph 16 in the Chinese version, it is different. The wording is slightly different, but the meaning is the same. In English, it is the same. In Chinese, it is not just a translated version of the English version. The Chinese version is an independent version. We would consider other aspects such as readability. That's why I think that what we have right now is appropriate. Chair, I disagree, because the English version, paragraph 2 and 16, are different. Are the same. I don't see any reason why the Chinese version would have to be different. When they say in the Chinese version, using different wording for having a terminal illness. I do not understand why this is necessary. Well, I can perhaps supplement the administration's answer on this. Before, they were stricter. That's why they would have the translation they had before that may not be as much of, that may not describe things as well. I think we have a progression here when we have a more flexible approach to the Chinese version because it provides better readability or it conveys the meaning better. So I would suggest, Mr. Rincon, if there is no significant deviation from the intended meaning, I think we can agree with the administration on this. But of course, I'm not trying to speak for the administration. It's just that I want to explain what Mr. Mo probably meant. Mr. Mo, do you have anything to add? Thank you, Chair. Indeed, the second paragraph was indeed drafted at a time when we did not do as well in terms of the drafting of the Chinese version. We do want to improve on that. That's why we have now a different translation for paragraph 16.
There is an improvement in terms of the phrasing. Under D2, in Chinese, we scrap the word person and we stick to the tenses in English. The point is to express the idea that the deceased was before the death diagnosed as having a terminal illness, so we opt for a more concise expression in Chinese. All right, I accept that, Chair. I have a follow-up question. We're making recordings in these meetings, and this will help us review the law if needed in the future. I just want to know whether the diagnosis can be made both in writing or verbally. Normally, we go to see a doctor and we get a medical record from the doctor. So if necessary, the doctor wants to check whether the patient is suffering from terminal illness, the doctor can always check the medical record. Well, the court will look at the provision if necessary in the future, and this is crucial to both the residential care home concerned and patient's family. Is there a time frame for before the death, or any time before the death? Well, we do not specify a time frame here when we say before the death here. I guess the administration doesn't want to make it black and white that the patient would, to imply that the patient would die after he is diagnosed to have a terminal illness. My question is whether a doctor will have to make it clear that the patient is diagnosed to be a terminal patient, to make it clear. Perhaps Dr. Luke can assist us, or other doctors can assist us. is it not humane to write in a note that the patient is terminally ill? Well, I believe the note will help the court or the patient's family members, but you don't want to write it black and white that the person is terminally ill. So how are you going to make a balance here? Yes, doctor. I believe a terminal patient, especially an elderly patient, he would usually indicate his wish to his family about his post-death arrangement. So we normally put it clear in the record that the patient is terminal patient, and we would be honest to the patient. And we have to make it clear, especially for patients who opt for dying in place or dying at RCHEs. So we will make this clear in the medical note. Ms. Lillian Kwok. Thank you, Chair. I want to see clarifications on the time frame as well. In point 2, it says that the deceased was before the death diagnosed as having a terminal illness. Say a patient is diagnosed to be suffering from lung cancer a year before his death. Is that considered to be a diagnosis made before his death? What if the diagnosis was made 2 or 3 years before the death? Is it the case that as long as this is covered in the medical record, then this meets the requirements for dying in place or dying at RCHEs? Also, my other question is about the 14-day requirement. For dying in place, you impose the same 14-day requirement. What are the rationales behind making it 14 days, but not a longer or shorter time? I asked the same question last time, but I didn't get an answer from the administration. Deputy Secretary. Well, in the original ordinance, there is the 14-day requirement. So before a doctor certifies a patient dead, we think that it's reasonable to impose a 14-day time frame before a patient is certified dead. I think the 14-day time frame can reassure all parties involved. What if a patient is first diagnosed as having a terminal illness, but then the medical condition changes and he's no longer a terminal patient? Yes, Dr. Luke. Most elderly patients who are terminal patients and there is a reversible change in their conditions, that's not common. Usually, the illness may span for years. We would follow up on the patient's condition in the final stage of the patient. The patient would have to go in and out of hospitals and he loses appetite. These are all warning signs that tell us that the patient is entering his final stage of life. For patients suffering from organ failures, it's usually hard for them to reverse the situation, especially those who suffer from heart diseases or other types of diseases. We regard these as irreversible medical conditions. There may be new treatments that help patients recover for some time, so we'll have to rely on clinical judgment to see whether a patient is suffering from terminal illness. I have come across different cases, and there are usually different periods to which a patient suffers from terminal illness. Does that mean as long as you put terminal illness on your medical note, we can guarantee that the patient is a terminal patient? Say a patient is diagnosed to have a terminal illness 5 years ago, and 5 years later the patient is still alive. So can we still regard that patient is a terminal patient. According to my experience, say for elderly patients suffering from Alzheimer, well, predicted death is usually not very accurate. For cancer patients, the diagnosis is usually more accurate. However, for elderly patients suffering from dementia, it usually depends on doctors' clinical judgment on when the patient would pass away. Say for some patients, we think they would pass away in a few months, but they end up surviving for a few more years. And there are cases otherwise as well. You're right that some cases are more stable than we think they are. However, for elderly patients with Alzheimer's or dementia, we thought they are stable cases, but then they may pass away all of a sudden. We hope that we can provide palliative care to these patients. We also hope that these patients can opt for dying at RCHEs. For some cases, they may improve through time, but for other cases, we regard them as terminal patients. Chair, I have a follow-up question. You mentioned about cancer patients. In terms of new treatment, there are treatments that help these patients recover. We have to take into consideration RCHDs as well, that is residential care homes for people with disabilities. People aged 18 can be admitted to RCHDs. So we have to take that into consideration. They aren't all elderly residents. I think the public should know what your considerations are when you take the so-called balanced approach. You mentioned that you should strike a balance between different factors. Apart from taking into account doctors' considerations, what about patients and the family members? Would they find these reasonable? In the existing law, there is a 14-day requirement imposed. I just want you to clarify on why you put the 14-day window so that the public can have better knowledge about this. I would extend this meeting for 15 minutes first. On the point about 14-day requirement, I'll ask Dr. Luke to tell you more. Dr. Luke? Well, according to my understanding, if a patient is having a terminal illness or is about to die, we look at their conditions in a 14-day window. Well, 14 days, according to my experience, we have to look at the patient's conditions for 14 days to decide whether his death is a natural death or has to do with something else. If it is a longer time frame, then it may be far from the diagnosis or far from when the diagnosis was made. As mentioned by the Deputy Secretary, this is not evidence-based, but this is a result after a balance is struck. I don't have any medical information to prove that 14-day is an appropriate window, but I personally find that the 14-day requirement is acceptable. Chairman, I have a few thoughts. As mentioned, this is just a minimal window or time frame. In your outreaching services, you mentioned that the doctor visits the RCHE once a month. So I wonder if you should tie in with your outreaching services and make it a 1 month time frame instead of a 14-day time frame. I think we can look at whether the 14-day requirement is appropriate in this particular legislation as well as other legislation. Yes, Ms. Doreen Kong. I don't want to dwell on the point about the 14-day requirement. My personal view is that for point number 3 under Section D. I had a family member who suffered from terminal illness. If we have the condition number 3, I would be very, very worried. How do I know if it would be his last illness? What if there were 15 days before the death when a registered medical practitioner attended the patient during his last illness? Understand that doctors see their patients very often. I have experienced the death of my father. I understand how painful my father was. My father was suffering from cancer. He was under a lot of stress. And you are asking the patient to see a doctor 14 days before his death during his last illness. I think this is totally irrelevant and unnecessary. Also, on the point about drafting, why can't you make it more straightforward by saying that, or by just requiring that the patient was diagnosed as having a terminal illness? Why do you have to mention in point number 3 by specifying that it is during his last illness? What do you mean by during his or her last illness? This is my question.
Well, I do understand that we have to adopt the principle of readability in this regard. In drafting aspects, do you have anything to add, Mr. Gilbert Mo? Well, there is a policy intent when we put in specifically that the registered medical practitioner has attended the deceased during his or her last illness. What is the policy intent in particular, Chair? Well, it provides a better flow. I don't think it will provide a better flow. If we remove the wording last illness, during his or her last illness, it will not achieve what we want to do. That is, one may not necessarily have an illness before the death, apart from the terminal illness. Even if the person is not suffering from anything in particular, we would require the registered medical practitioner to have attended to the deceased. We believe the full set of wording in subparagraph D3 would be required. Well, I don't understand, Chair, because the deceased was supposed to have already been diagnosed as having a terminal illness. If they visit a doctor or a doctor has attended to the deceased, of course, that would be the case because this deceased already had an illness. So you said the deceased was diagnosed as having a terminal illness. They would not suddenly recover from the terminal illness. So I do not understand why the wording last illness is necessary. Are you saying that they need to have another illness that they have to seek assistance from the medical practitioner so as to meet the relevant conditions? I don't understand. So I think the administration has to be specific whether last illness would refer to another illness or the terminal illness, or is it the case that since they have already diagnosed as having a terminal illness, and then there is a different illness that has caused the death, because there are different causes of death and there are multiple diseases that can cause deaths, and we would need to know which specific illness that causes death. Is that why you have a difference in wording? Deputy Secretary, perhaps you can talk about the policy intent. Well, thank you, Chair. When they said the last illness, it could be one fainting or having pneumonia. That's why we would want to provide for that, because it may be different from the terminal illness. Would that help with your understanding, Ms. Doreen Kong? So it wouldn't mean the last illness, it would just be before death. Chair, I believe you have explained it quite well. For example, when one had a heart failure or pneumonia, that would be different. Chair, let me be clear. When one has a terminal illness, like under what circumstances did they die? For example, whether they had pneumonia or cardiac arrest that caused their death. I wouldn't know that. Since you're already trying to remove restrictions, why do you have to make the conditions so strict? Chair, I don't understand. Well, the administration, if you have already drafted such strict conditions, it may be hard to implement. Would the administration consider, perhaps not in this stage, remove more restrictions that are in place? Chair, will definitely review that, but as said earlier, the 14-day requirement is quite natural, because before one dies, often people would feel ill and they would have to visit the doctor or require attendance of a registered medical practitioner. We can definitely review in future whether other amendments are needed. Well, let me put it this way. For someone who has a chronic illness or one has dementia and one falls to their death, would that complicate things? Well, I wouldn't think it to be the case. This would still be determined as a natural cause, and but for accidents, they would have to be reported, so it will still be a reportable death. Ms. Doreen Kong, I think unless you object to it, there is nothing you can do at the moment. I understand, Chair. I just hope my comments will be noted by the administration and, if possible, incorporated in future legislative amendments. I hope they can just improve the wording in the future. Well, I must say the existing provisions have existed for 10 odd years. It should be alright. So we have completed the scrutiny of the Coroners Ordinance Amendment of Schedule 1 Notice 2023. The other notice would be more or less the same. Can you be brief with the Chapter 174 notice? Well, thank you, Chair. It is a consequential amendment because it quotes the contents in the Chapter 504 notice. Any comments to be made by members? No? Alright, in relation to English version, as Ms. Doreen Kong has already discussed the Chinese and English versions, I believe we have scrutinized it, but we'll ask the legal advisor anyway. legal advice, any legal or drafting issues with the English version? I see none of that, Chair. Thank you. All right, so with the legislative timetable, I understand that on the 17th of January, we will apply for the scrutiny period to be extended by resolution. After that, we'll report our deliberations to the House Committee. Well, this is dealt with if members have no objections. In relation to what Dr. Tick said about the details about the policy considerations, the administration can provide them to members after the meeting, but we consider them to be immaterial in relation to the scrutiny. If necessary, we will hold another meeting. Otherwise, we will go through that unless members have other questions about the information to be provided by the administration. The deadline for submitting amendments will be 14th of February of this year. Any other follow-up by members? Apart from the concerns expressed by members, is there anything that we have to deal with at this juncture? If not, this will be the end of the meeting. Thank you, members and public officers, for attending the meeting. Meeting adjourned. Thank you. Thank you, Secretariat.